All right. Good afternoon. Thank you very much for joining us at the Nova Eye booth for our discussion of the iTrack Advance. I wanted to just take a moment to get our introductions out of the way.
Good afternoon, everyone. My name is Dr. Constance Okeke. I'm a glaucoma specialist and cataract surgeon based out in Norfolk, Virginia. I work in a multi-specialty group practice, and I've been doing iTrack for quite a number of years, and now have moved on to using iTrack Advance.
My name is Billy Pan. I am a glaucoma specialist in Beverly Hills, California. And similar to Dr. Okeke, I've been using the iTrack, the prior generation as well as the Advance now since it's come out for quite a while. So today we're going to be talking about the Advance. We're going to look through just some history of canaloplasty. We're going to, I believe, look at some surgical videos. And then we'll talk a little bit of data. And I would love just to hear your thoughts about the procedure, your way of doing it, your tips and tricks, and then get everyone on board of how to actually best tackle this new technology.
Yeah, so when we're looking at the outflow system, we know that there are certain areas of resistance. And one of the great things with the device is that it does affect and have an effect on all the different areas of the pathway of the trabecular outflow system. So just like with medications, I say this, we use multiple different medications with different mechanisms of action. And part of the reason why I like the whole concept of being able to address the outflow system is because there's multiple areas that we can address and attack that can help to open up and allow for increased flow. So we have the trabecular meshwork, which is the filter. We have the Schlemm's canal, that can have adhesions, that can have ability to get flattened. And then we have the outflow system with the collector channels that have ostia that need to be made more open and potent for there to be more flow. So by using the iTrack, we're addressing all these different areas of the outflow system in order to get an increase and enhanced outflow.
I completely agree. I think one of the interesting things about glaucoma is for the longest time, we never had any medications that was directed towards the diseased tissue until actually just 5-6 years ago, right?
Right, recently.
Everything else was tackling, inflow or supplemental outflow, but the iTrack has always been available to directly, surgically tackle the system that was at fault for the glaucoma and the disease. So a little bit looking at the collector channels. The collector channels, they can be partially obstructed, they can be fully obstructed, or they can be open depending on the level of sclerosing, the level of disease, the longevity of the disease of a patient with glaucoma, right? So when we get a chance to pursue canaloplasty, we can target, as you mentioned earlier, the entirety of that system, starting from proximal to distal, including the collector channels, where if they are blocked, either partially or fully, we have an opportunity to actually open them up and reestablish kind of normal flow that patient is missing. Thoughts?
Yeah, I remember when I first saw this slide like years ago, and I was kind of like a little bit taken aback about it because, we think about the area of resistance really within the trabecular meshwork and there being some type of impedance of flow because there's a clog within that space. But when I saw this slide and kind of conceptualized how the Schlemm's canal can really flatten and also herniate into the collector ostia, it really kind of opened my thought process up of what's really happening when we're taking the catheter of the iTrack and moving it within the canal system and helping to pull out these herniations, open up that canal, and then really use the pressurization to kind of flush it out. So it's really great to be able to have access to dealing with a certain type of mechanism that we don't really have the potential to see.
I don't know in your experience if you felt like when you're advancing the iTrack, sometimes you can feel areas of adhesions, and whether those are adhesions within Schlemm's or maybe they're actually herniations of the collector channels into the canal. But the tactile feel of this device, it's delicate enough where you can actually get quite a bit of good feedback.
Yeah, I mean, and that's also, just like with the mechanism, like you're saying, when you're feeling an obstruction and then you have that tactile feel, using the the viscodilation to be able to help to open that up, it's really great to be able to see that, okay, I'm making some kind of impact when I kind of viscodilate that space, and then now I'm able to move past it. So, yeah.
So catheterization, do you do 360 as
Yes.
much as you can?
Yeah, as the beauty of the iTrack is that you know where you're going. You see it with the illuminated tip. And so if I have the ability to go 360, I'm going to go 360 unless I'm restricted.
In terms of catheterization, how much would you go if you had a blockage and say, I probably had enough? Is there a cutoff? Because sometimes we can't get entirely around, right?
Yeah, I think that, if I've gotten at least 270 degrees, I probably wouldn't try to go and make another pass. If I've gotten maybe 180, I might think that maybe I should try to get a little bit more.
Yeah.
So that's kind of where my gestalt is.
Yeah. I'm in full agreement. If I can get about 3/4, I'm pretty happy with that. And the good thing about this catheter is with the blinking light, of course, you know where you are at all times. You're not going down false passages, or if you are, you can catch yourself early, and you're going to be delivering the viscoelastic to where you want it to be.
Exactly.
So viscodilation, the catheter goes 360 degrees around, and then once it's 360 degrees around, or even on insertion of the catheter, you can have viscodilation, right? The priming of the device allows the elution of viscodilating material, regardless of which one you're using, through the device to open up, again, Schlemm's directly, and then proximal as well as distal outflow. So in terms of viscodilation, did you have a preferred viscoelastic that you like to use, Dr. Okeke?
Yeah, I typically use Helon. I have been happy with using that. I feel like I'm able to pressurize the chamber, as well as not feel like it's too heavy. It's like a GV or something like that that I'd be concerned about having pressure spikes. So I typically use Helon Pro.
Yeah, me too. I like Helon Pro. I think I get a really good response with it, and it's pretty readily available, right?
Yes.
Some surgical centers, they might not have something heavier like a GV, and I think there's also shortage for a period of time, so Helon Pro has been my go-to as well. With the viscodilation, do you routinely see blanching?
So it can vary. I think that it's a wonderful thing to be able to see blanching happen during the part of the removal and the release of the viscoelastic. It kind of feels reassuring, but at the same time, I can't say that I will hang my hat on if there's no blanching, I'm not going to get an effect. So in the operative setting, it's something that's very encouraging and helps you feel more confident.
Yes.
However, I won't say, I have correlated not seeing it with not getting efficacious results.
I fully agree. I see it, I would say, anecdotally more than 50% of the time. But even with the times where I do not, the effect of it is always immediately apparent post-op day one anyways. The pressure is down very nicely. And beyond the distal collection, do you see egress back into the anterior chamber sometimes?
So sometimes you're going to get a little bit of some regress of heme, especially if the pressure has become much lower. Sometimes when you're looking for blanching, you're looking for it during the viscodilation delivery. But then also, if you are looking there, but you may also see it later when you're hydrating the wounds and pressurizing the chamber, you may be able to see some more flow at that point too.
Yeah, absolutely. One of the things that I do, and this may just be me, I refill my anterior chamber with viscoelastic before I start doing my clicking, just to tent everything up. And so it is packed to the brim of viscoelastic. So sometimes when I'm removing the device and viscodilating, I'll see that there's viscoelastic burping out of the main wound a little bit. So I know that there's also viscoelastic coming into the AC through the TM. And so that is also one of the areas I think that the device really excels in, which is, helps to create those micro cracks and micro perforations in the trabecular meshwork, which can reduce a little bit of that traditional juxtacanalicular trabecular meshwork outflow resistance.
Exactly. And I think that when I kind of first, conceptualized that, you're using that pressure to exude in the back through the collector channels and the and then that the distal pathway, but also the trabecular meshwork is a filter. So you're also coming on the other side
Absolutely.
internally, and it's like flushing out the filter. So
Absolutely.
yeah.
All right. So the iTrack Advance, this is the product that we're here to discuss. The original device you have used, I have used, it was a great device. It required more finesse. Would you agree with that?
It required more finesse, and it also had a number of extra steps that took something that gave you a great result, but wasn't quite as efficient in the OR.
Agreed.
And it also, sometimes with all those extra steps, they just made you have to have a little bit more tedious finesse
Yes.
to be able to do them. Yeah.
I agree. And I think because of that, there were those who really loved the product, really loved the procedure, and really loved the results that we got. And so there were a lot of those who continued to use that device because it was just so good in our hands. But this year we've had the iTrack Advance, which has basically put that same product into a delivery system that has made it much more accessible. Would you agree?
Oh, much more accessible and then much more efficient. You were able to just get direct to the angle, and by being able to be more direct, you are again allowing a more efficient surgery and a more elegant surgery, being able to use less manipulation in and out of the eye.
I agree. And this device has also been the trendsetter for canaloplasty. This was the one that was available for ab externo, and then ab interno, and now ab interno with a new delivery device. Okay, so I believe we have our first video here. I think there's a couple. Dr. Okeke, did you want to kind of just narrate us through Dr. Singh's work here?
Okay, so it's always important to get a good on-face view of the angle so that you know where you're going. It's also a good step to prime the catheter, especially if it's been sitting for a little while, so that you know that you have a pressurized system. So you can use that step of putting viscoelastic on the surface to kind of help prime there. So again, he's making sure that there is viscoelastic on the surface as well as inside the eye, and now taking the iTrack device, and one of the new features is the tip that can very easily make a small goniotomy within the trabecular meshwork, so that the delivery of the iTrack catheter is very simple. And as you can see, he's already actually zipped all the way around, and you see it internally here. So it's made it a much more efficient and direct approach to get to the angle, to be able to use the tip to make a small goniotomy and to deliver the iTrack. And now he's delivering the viscoelastic, slowly pulling the sleeve of the device, pulling the catheter out, and you can see that there is pointing out where there's some dilation of the vessels as he's going around, and you can see the blanching. Again, he's showing how there is specifically the dilation of those vessels as he's pulling the catheter around, and the viscoelastic is exuding from the tip.
I think Dr. Singh made that look effortless, but also really realistic of what one can expect when doing a case like this.
Yes.
All right. So pressurized viscodilation. This slide is kind of similar to the slide with the collector channels earlier, showing that there are herniations in the collector channel in patients with progressively more severe glaucoma, perhaps, and that viscodilation can increase the opening or increase dilation of what was previously blocked. I think this device is trying to show that that was the distal aspect. This is kind of the proximal part of the conventional outflow system, right? Where the trabecular meshwork can be very, very closed down. And the thought process is when you viscodilate, right, you kind of break through or microperforate the trabecular meshwork, so there's a little bit of better porosity. Thoughts?
Exactly. So with more porosity, more openings of those that architecture, you're going to have ability to have more flow.
All right. So Dr. Kiami is really one of the founders of this device and is a leader in the field. This device is, I believe, with the iTrack 250A, so not with the Advance, but this is a surgical video that is showing how the viscoelastic actually goes down and also up in terms of downstream and upstream of flow. So when you mix Trypan Blue with viscoelastic and you're injecting it along the way, you're able to see that there is blanching across the entire rim on the outside of the limbus, where there's been viscoelastic delivery, but also you can see that 360 degrees around internally, the blue is egressing inwards, and that's showing you that the trabecular meshwork is getting the microperforations, increasing the porosity, increasing flow, and reducing resistance internally. Dr. Okeke, does this look like your patient or my patient? I know we both sent videos in.
I know.
I don't know either.
I can't tell.
I can't tell either. So this is one of our patients. And I think this video is going to show something probably pretty similar to Dr. Singh's earlier.
Yeah, I think this is your patient because I don't think I used the Glaucoma.
Oh, okay, got it. So the differentiator is the prism of choice.
Prism, yeah.
So this is one of my patients then, pseudophakic after cataract surgery. So I prefer to do this procedure after cataract surgery. Again, you have the tip of the cannula, which will incise the trabecular meshwork. The way that I do this is I tilt the tip upwards a little bit, about 30. Sometimes I exaggerate 40 degrees. And that helps the catheter, when it comes out of the cannula, to slide right into Schlemm's canal. At least I found that works really well for me. Mm-hmm. Now, the 360 canalization here is relatively slow, mostly because I want to watch it go in a controlled fashion. You probably can agree that if you just depress the actuator, it goes around pretty quickly, right? It can.
Yes, it
almost
can.
Instantaneously.
Mm-hmm.
Afterwards, I take off the prism so I can watch the light come around. I like watching areas of blanching to see if I can see it. And during this process, I have actually one hand free. But this way, I have the ability to put on a gonio prism if I need to. And my technician at this time is basically clicking down the catheter as I'm counting out, right, the number of clicks. And you can see proximally, especially towards the main wound and between that and the paracentesis, that there is the blanching there.
Yeah, and also one thing you spoke to before, I'm seeing the egress of viscoelastic out of the wound, which is going again to what you're talking about, all that viscoelastic that's also entering the anterior chamber to cause that egress of that.
Absolutely.
Visco.
I think the egress in is harder to appreciate unless there's blue there. But also, as I mentioned before, I really like to tank up the eye before I viscodilate, so that ultimately, usually my patients get the egress just because I do that. Yeah. Do you like to do yours before or after cataract surgery?
I typically do mine after cataract surgery. It's funny how when I first started with MIGS, I always did MIGS first. Mm-hmm. But then I think that, as you develop a skill set of doing mixed procedures and a finesse with doing them after is okay too.
Yeah.
I think that there is advantage when you're maybe earlier on because you want to have a very clear view.
Absolutely.
Of maybe considering doing it first, but I typically do the iTrack second.
I agree. I think the benefit doing it before is, as you said, you have a pristine cornea, and the benefit doing afterwards is the angle may be a little bit more open, although with viscoelastic, the angles are usually very open. All right, so what outcomes can we typically expect with the iTrack Advance? So one of the earlier slides I think we saw is that the iTrack in its current generation and its prior has been around the longest. And so there is a substantial set of literature out there supporting the effects of the iTrack device in canaloplasty, which is the same procedure. We're just making it easier with the current generation device. Mm-hmm. The results here, I think, all kind of speak to themselves. Mm-hmm. I think the easiest way to look at this graph is probably to see that preoperatively, you're in the usually around the low 20s, and then postoperatively, you're in around the mid-teens. And that's episcleral venous pressure, right?
Right.
With this device and with any conventional bypass device, we're not going to get anything lower than that. So this is 14 to 16 range, that's about as good as it gets. Do your patients feel like they kind of settle in around this range?
Yeah, I think that it's very typical for patients to settle around in the mid-teen range. But then also the nice thing is that a lot of them are getting off typically at least one medication, sometimes more than that.
Absolutely.
So the beauty of it is being able to see these kind of consistent low pressures and also get them off typically at least one medication, which does also help with their corneal surface. If they have dry eye, it can help with the fluctuation of vision post-operatively. So very good results overall.
I think in the patients that I bring to surgery with canaloplasty, the ones who are already at target pressure but they're on a bunch of meds, the most exciting thing that I can't wait to tell the patient is, we can get you off of one or two drops. Sometimes if it's a home run, maybe sometimes all of them.
Yes.
Right? That makes me feel great when a
Yeah.
patient can get off of the drops that they've been using and expecting to use for the rest of their life.
Yes, and sometimes it can sometimes be a little bit of mind shift because let's say someone's a cataract surgeon and they're doing surgery on a glaucoma patient, and the patient is already doing well with their drops, and the patient's not necessarily complaining about doing two drops. But the reality is that sometimes if you ask the patient if you have the opportunity to come off your drops, the majority of them would be excited to be able to have that opportunity. And so when you're letting the patient know that you have a cataract, and because we're in the eye, we have an opportunity and access to your natural drainage system, we can use a device that allows us to go into your drainage system, clear it out, flush out, clear out clogged material so that it can be enhanced with more flow, and more flow means lower eye pressure, and that it's a win because you may be able to get off a drop. It is a slam dunk, and it
I agree.
makes, it makes our job, satisfying because we know that afterwards the patient's going to be more satisfied too for multiple fronts.
I'm just going to share a quick anecdote because I saw this patient on Friday before I flew up here actually for AAO. It was a patient, kind of one of our typical patients, one eye more severe with compromise of the vision. I think she was around 2100. The other eye was her good eye, 2030. She was on drops on both eyes, I think 4 bottles. And the bad eye was starting to get really intolerant of one of the medicines. So I said, let's do this. She was very averse to anything because she was using drops for 20 plus years and she was living and dying by her drops. I took her in, we did an iTrack. I saw her Friday morning for her post-op month 3, I think. Her pressures were around 12 to 14. She was on 2 of her 4. Her eye looked much better. Her good eye was really bothering her. And that was the eye. She wouldn't let me touch either eye. But the bad eye, she said, okay, let's do it.
Something there, yeah.
But now she wants me to do the good eye.
The good eye.
Because the experience was so good. It was so
good.
quick. Recuperation was easy. She was happy about the fact that she felt better too.
That's awesome.
Yeah, I'm
That's
sure you've had
awesome.
patients like that as well.
Oh yeah, yeah, and that's like a slam dunk. It's when you're able to the trifecta, when you're helping them see better, when you're helping them to either get into control or have less effort in staying in control, and also what it does for the ocular surface, because a lot of our patients with glaucoma have dry eye. When you're able to also help that indirectly,
Absolutely.
like I said, it's a slam dunk.
Absolutely. All right, surgical pearls, patient selection. I think the easiest way to talk about this is probably just real life experience. Your step by step?
For doing the procedure?
Yeah, for the procedure.
Kind of for me, it kind of depends on which eye I'm doing because I'm a superior sitting cataract surgeon. And so when I go temporally on the right eye, I'm going to make a incision right around that 6 o'clock. And I'm going to usually prime the catheter like we had talked about earlier to make sure that it's pressurized by putting some viscoelastic on the surface. Then I'm going to make sure that there's enough viscoelastic within the eye. And then with the handpiece, it's mobile. So I'm going to kind of adjust it so that it's going to be so that the bevel is going to be angled up just a little bit. So when I enter, I'm about 10 to 15 degrees when I'm entering the trabecular meshwork in this position here. And so I don't think we showed my video, but one of the techniques that I have done before with the tips of the devices is to do like what I call a slice technique. So I actually just take the tip and I just make a slight slice of the trabecular meshwork and a dimple down. That just kind of creates a goniotomy opening for me. Now, the way that the device is designed, you don't have to do that because the tip is good enough to be able to pierce into the trabecular meshwork, but that's it's a kind of a technique that I just do and use. But after you've established a position past the trabecular meshwork and now in Schlemm's canal, the way that the device is, it has a lever that you just push forward so that you can get the catheter within the track. And now it's illuminated, so you can really see that you're in the right space as you're going and tracking. So visually, you're seeing as you're tracking under the gonioscopy, but then I lift up my gonia prism, and then I watch it go around 360 degrees, and then I'm going back on gonioscopy, looking to see that it's come back around at that part.
So I think we actually covered this.
Yeah.
I think the incising is actually probably harkens back to when we did the 250A, where we had to create a goniotomy, right? Mm-hmm. It's brilliant. But as you said, the device itself, it does a pretty good job getting into the TM itself.
Yes. So you don't have to do a lot of manipulation.
You don't have to do much at all. I agree. One of the things about the cannulization of and the catheterization of the canal is sometimes I turn the scope light off, and I just watch it track around the limbus. Mm-hmm. Sometimes with the scope, when the light is so bright, I actually might lose it.
Yeah.
And so turning it off, everyone can see the room. All the scrub nurses. If someone hasn't been with me when I've done this procedure, they're very excited. They're very excited to see the anatomy that is actually in play.
And again, the beauty of doing that, if for any reason there's ever some type of obstruction or you're not seeing it, you can turn off the light. And then if it's for whatever reason not in the right place, you can also just pull back and get back on track. Yeah,
absolutely. Mm-hmm. In the event that happens, how do you sometimes troubleshoot it?
Yeah, so it kind of depends on how far along where I am, because if I find that I'm kind of diverting off path, I may pull back and then try to slowly advance again. If I end up going back in the same path, then I may pull back, and then maybe at that point, depending how far along I am, if I'm further out, I might do a little bit of clicks of viscoelastic to kind of try to see if I can maybe push away, maybe whatever helped me divert in that direction. Sometimes if it's earlier on and I feel like it's dived in the wrong direction, I might pull back and consider creating a new track and kind of starting over again.
Yeah, I agree. Everything the same. So viscodilation we talked about a little bit earlier, which is that we both use Helan Pro. I think Helan Pro and ProVisc are probably pretty similar in terms of the viscosity and the density. Mm-hmm. And so 9 clicks per quadrant. I think I end up probably counting anywhere from about 40 to 50 clicks over 360 degrees on average. Yourself, any thoughts?
Yeah, I do it with my scrub tech. I'll have her count out about every 9. So I'm going per quadrant.
Very good.
1, 2, 3, up to 9, and then again. And I tell her again. And then I'm doing that. So she's counting, I'm tracking, trying to stay within the quadrants for that. Mm-hmm. That's what my approach is.
And I think if someone uses GV, because it's a denser viscoelastic, we're going to reduce the counts.
Exactly. Okay, so here's
perfect.
mine. So here I like to kind of get a good feel of how the catheter's coming out and kind of get my thumb moving in the right direction. And then I prime the tip of the catheter by releasing some viscoelastic. I kind of make sure I check to see the pressure because I want to make sure it's well pressurized before I begin, and I fill it up with viscoelastic again so that it's nice and taut. Then I'll be ready to go in with my device, approaching the angle, putting my gonios lens on, and trying to get the best en-face view. Here is my slice technique that I was talking about, making a slight little incision and pulling down, and then using that as a starting point. Angling up about 10 to 15 degrees, entering and watching that the device is going in the right space by looking at the catheter and seeing that there is some level of no resistance as I'm going through. kind of zipped along, and you can see I kept the gonio prism here, and you can see that I've already now gone 360 degrees. Now I'm talking to my assistant, getting her ready to kind of pull back and counting the 1 to 9 that she's doing per quadrant and looking for being able to see any kind of blanching or just signs that I'm keeping up with her count and per quadrant. And then I finish.
That's a perfect surgery.
Okay. Okay, we can advance because I think I'm just hydrating here.
So these must be some of the trickier ones, right?
Yeah. So this was okay. So this was a situation. You know, sometimes there might be some challenges within the in the setting of the surgery. So I've done my cataract surgery, and I placed. I'm now looking for my view. I've made an incision for where my device is going to enter. I'm making sure that the area is well pressurized by putting viscoelastic into the AC, making sure to remove any visual obstructions like the bubble, which I eventually get out. I'm here priming, again, the tip of the iTrack, and I'm entering. And as I approach the angle, I'm now kind of doing my little technique of the slice and then entering. Now, what happens is right here, as I'm entering, you can see that you can't see the tip. So I've gone a bit in the space that is not the Schlemm's canal, and the patient felt it and flinched. And so here I am saying, okay, can I, recoup and assess? And trying to go into the same space wasn't the best option. So I went a little bit more anterior, created another track to try to make another area of a goniotomy, and then was able to do that a little bit more anterior. And now I found the right track and the pathology of the Schlemm's canal to be able to do the case to be able to complete it well.
Absolutely. I think when the catheter goes not in the canal, if it goes deep, the patients are really good about letting us know.
Yes.
Although occasionally there are some very stoic patients that it's going completely in the wrong direction and they don't make a sound.
Yeah. And the other thing about the technique is that this has a little bit of a speed increase here, but I do tend to be slow and deliberate to be able to get that tactile feel so that one can also use those as cues to help with the procedure.
All right, patient selection in terms of severity, with or without. Let's see. We'll bounce back. You want to take glaucoma severity? What are your thoughts of the types?
I think that, in terms of wanting to address patients who have trabecular meshwork that is not too scarred, one wants to still consider in the mild to moderate scenario. Now, have I ever done it in patients who have a little bit more moderate to severe, where maybe they're controlled already on medications and my goal is to get them off at least one medication? Yes, I've done it in those scenarios. But I do tend to target patients with more mild to moderate disease that are open angle.
With or without cataract surgery, I think that, well, first of all, this device can be used with or without cataract surgery, right? So we have the freedom to do so if they're phakic at the time of cataract surgery, phakic without cataract surgery, or when they're pseudophakic. So I do probably about 75% at the time of cataract surgery and about 25% standalone. Your breakdown?
Yeah, it'd probably be very similar. I think that, the whole concept of using MIGS as a standalone option is something that we're still continuing to adopt. I have done it in patients who are pseudophakic, but also in patients who are phakic, if the scenario presents itself. So patients who are on maximum medical therapy that they can tolerate, who've maybe already had laser treatment, who are in need of some type of additional procedure because they're progressing, this can be a great option to help them avoid a more traditional glaucoma surgery as a standalone procedure.
I agree. And then controlled versus uncontrolled. I think we probably actually touched upon that a little bit. That's it. All right. Thank you, audience, for being such a great audience.